Hello, I'm Björn Dollev, CMO of Cereno Scientific, and today I'm joined by Professor Mike Holinstat from University of Michigan, Director of Translational Research and also involved in Cereno's preclinical development programs. And I'm also joined by Gunnar Olsson, a physician by training who has worked almost his whole life within cardiovascular research and drug development and mainly in AstraZeneca, and now a member of our scientific advisory board. Today we are going to discuss thrombosis and its treatment and prevention. And the first I want to discuss is, why is it so important to address thrombosis as a clinical problem?
I would say thrombosis is it's a first-line problem for myocardial infarction as well as stroke. And targeting the platelet and preventing thrombosis is first-line therapy for a long time, and yet we still, 1 in 3 people die of a thrombotic event.
Yeah, isn't it true that thrombosis is #1 killer in the world?
It is, but we should also remember that it is also the cause for many non-fatal disease states. So it is something that is very frequent in an ordinary population.
Thrombosis being very important. Can you explain the pathogenesis behind the thrombotic event?
Yeah, so when we think about thrombosis, we think primary and secondary hemostasis. And the challenge with treating thrombosis is that you need to clot when you have a vascular injury so that you don't have a bleeding event. But if we are too good at preventing that clot, then you will bleed. So we don't want to occlude the vessel, we don't want to bleed. And so it's a big challenge to know when to treat and to what extent we need to intervene in order to keep the hemostasis in check.
What do you see as the most medical unmet need in the prevention and treatment of thrombosis?
I think going forward, we need to think about treatment as further preventing platelet activity and activation without getting into a bleeding risk. It's a very challenging area, and we've seen that dual antiplatelet therapy, antiplatelet anticoagulant dual therapy often shifts us into the bleeding risk. So that's, to me, is the biggest challenge moving forward with new therapeutics.
I would agree. I think that we have very effective drugs both on the platelet side as well as on the anticoagulation side. The problem is really to have effective therapy without driving bleeding risk.
But is it true that you cannot push the doses to full efficacy just because of the bleeding risk?
I think that this is also different between different patients. In the uncomplicated patient, you can usually use the standard doses, which is often very effective. However, in complicated cases, it is often difficult to drive to ordinary dose levels without having also bleeding complications. So that's really where I see we have the major challenge with regard to antithrombotic therapy today.
So is it true that there is no real treatment of thrombosis today that doesn't have problems with bleeding?
I think it is true that there is no current therapy that does not carry a significant bleeding risk.
Is it possible to create such a treatment?
Yes, it is. We need to think in a non-traditional form. Current treatment targets 3 targets, and all treatments target either apinergic receptors, integrins, or thromboxane, prostaglandin. There are a number of targets that we could utilize that have a high likelihood of preventing thrombosis and significant platelet activation without moving into the bleeding diathesis.
We see that patients are getting older, which means that we often see more complicated patient cases. What I mean with this, just to take an example, that is that it's not uncommon that you have a patient with for instance, atrial fibrillation, which is seen as a low pressure situation where you usually use anticoagulants. That patient could later on suffer from an acute coronary syndrome episode where you need the antiplatelet. And then you need to combine the antiplatelet and the anticoagulant, and that drives the bleeding risk substantially. To have better antithrombotics to cover such broad range of different diseases without driving bleeding risk would be something that we are really looking for.
That's kind of the holy grail
Yeah.
in thrombosis.
Yes. I would add to that one of the challenges with anticoagulants is a rebound thrombosis. So it is well established in the clinic that once you remove the anticoagulant, the patient's now at an increased risk for thrombosis. And so identifying new therapeutics that don't have that long-term increased risk will be essential, especially in older population, postmenopausal women, diabetes, a number of these chronic diseases or disorders or conditions that already place the patient at high risk.
So what are currently the therapy for patients with the risk of thrombosis?
Well, first with patient we put on aspirin. As their risk increases, they'd be given dual antiplatelet therapy, so a purinergic, clopidogrel, or other P2Y12 inhibitor would be added to that. Patient who continues to be at risk could be put on triple antiplatelet therapy or dual antiplatelet therapy plus an anticoagulant. With each one of these therapies we add on, the risk for bleeding significantly increases.
But you're talking mainly about arterial thrombosis now.
In venous thrombosis, we would start with heparin. That's the standard of care. And then we might move to, if they were at risk for DVT, warfarin or heparin plus another factor Xa inhibitor or other anticoagulant.
And NOACs. Yeah.
Yes.
Yeah, and I mean, atrial fibrillation patients, in order to prevent strokes, we're using the NOACs. What is also an important area, that is people with repeated deep venous thrombosis. And of course, a deep venous thrombosis could result in a pulmonary embolus, which could be life-threatening. Due to the bleeding risk, usually the treatment period after a thrombosis is given for 3 to 6 months and then terminated. It is, however, clear that there is still an increased risk of a new thrombosis. But this is really the reason, or the reason behind that is really the bleeding risk that you have when you have an anticoagulant on board. So again, having new treatment modalities that would have reduced bleeding risk could actually mean that there would be better preventive therapies also for some patient categories.
So you foresee that patients with recurrent deep venous thrombosis would have chronic treatment if there would be no risk of bleeding?
I think so, yes.
And then just to add to that, while we often think of the arterial and venous systems as one being platelet-driven and one being fibrin-driven, it's well established now that even in venous thrombosis, platelets are the trigger. So by effectively inhibiting that initial trigger, we do inhibit a venous thrombotic event.
Okay, so you mean that it would be possible to treat the venous thrombosis with antiplatelets as well?
Absolutely, but the really ideal combination of treatment effects for new compounds, that would be, of course, to have a combination of both platelet effects
kind of
and effects on the fiber.
What do you think are the main drawback with today's therapy, and why can you not push the dose to a higher efficacy?
Well, first, when we think about new therapies or pushing a dose, we have to think about the fact that you have to add that to standard of care. So we cannot withhold treatment from a patient. Therefore, new therapies come at the higher risk of bleeding because they have to be given on top of an antiplatelet or anticoagulant therapy to begin with. And then efficacy, driving the dose to efficacy is just challenging in patients that are already at high risk, such as dyslipidemia, age, gender.
I would add to what Mike just stated, and that is to look at both arterial thrombosis, post-MI, post-ACS, and look at the deep venous thrombosis. You have the more aggressive antithrombotic treatment early on, and then the discussion is when can we sort of reduce the dosing because of the bleeding risk. Of course, if you had the ideal drug without the bleeding risk, you would of course continue to have the highest efficacy dose continue also in the long term. So it is definitely something that affects the physicians when they take decision about treatment. How will I balance the bleeding risk opposite the efficacy that I want to have? And bleeding is something that limits the full effective dosing over time.
That's a major problem.
Yeah, and that's what needs to be solved.
So what do you think are the emergent, most promising new therapeutic approaches lately?
I think some of the new factor Xa inhibitors have shown a lot of promise, especially the oral inhibitors. The oral 2A inhibitors show promise, but still come with significant risk of bleeding. And in the platelet field, there has not been significant success. The newest new therapy is 7 years old, and it has not translated to the clinic due to bleeding risk.
Do you think there is something in the preclinical development that holds some promise?
We start to see clinical data coming out for the first factor 11 inhibitors. It looks promising because it seems as they can produce the same anticoagulation effect as the NOACs, but with lower risk of bleeding. But we haven't seen the late stage development trials, so it's still a promise, but we don't really know where they will land. On the preclinical side, I think that some new data from HDAC inhibitors showing both efficacy on the thrombosis build-up, both in terms of antiplatelet effect and effect on fibrin, so it's a fibrinolytic effect. That looks promising, and here, of course, we have the compound CS014 that has, during this Congress, been presented for the first time. The preclinical data that looks extremely promising.
Mike, do you think there are other approaches that holds promise as well?
Yeah, so CS585 is a prostacyclin receptor agonist. It holds significant promise, especially based on its potency and selectivity in the blood. And it seems to be succeeding where other prostacyclin receptor agonists have failed. And so I think that holds great promise. And there are a number of targets still in the platelet that are unique to the blood and non-adherent cells. And so I think there are a number of promising approaches. But to me, CS585 holds really great promise, and I agree that CS014 also, for different reasons, especially because of its thrombolytic potential, holds a different avenue of promise.
So, but they are in preclinical, so
they are both
they
in
need to
preclinical.
prove their case in the clinical arena.
Correct.
And I know maybe you shouldn't be shy because you are actually one of the inventors behind the CS585.
Yes.
Can you tell us a little how that happened?
Absolutely. So CS585, we took a completely different approach, and identified a fatty acid lipid that binds to the prostacyclin receptor and was stable in the blood. And that was different than looking at prostacyclin, which is relatively unstable in the blood. And so we developed a new therapeutic based on that endogenous metabolite, and we're able to show very potent and highly selective targeting of the prostacyclin receptor. And for the first time, we were able to really target the receptor on the platelet for potential antithrombotic therapy. And we shouldn't forget that the first potential target for iloprost was the platelet and thrombosis. It was simply due to stability in the blood or instability in the blood that rendered iloprost unable to be used in this avenue.
Yeah, and I would just add here that I think it's the full picture that looks extremely positive. I'm thinking then about the factor 11 inhibitor that I talked about. What that has given rise to believe, that is that we can separate efficacy and bleeding risk, which was not clear with the NOACs that were introduced over the last 10 years. So but there is hope to really be able to do it. And then looking at these preclinical data where we have two different mechanisms working, antiplatelet as well as the fibrinolytic activity for CS014, that plus lower bleeding risk in the experimental setting is very promising, and similar for the CS585. So actually the factor 11 data has given us more hope that we will be able to separate the efficacy and the bleeding risk, also in the clinical setting.
In addition to factor 11, there are other targets that have shown the possibility of decreasing thrombosis without increasing bleeding. One being targeting proteins that are only in that cell. For example, 12-lipoxygenase is a prime example. A phase 2 study showing the ability to do that. And so like factor 11, we now know that if we get beyond the 2 to 3 targets that we've looked at for the last 30 years, we have a lot of promise in achieving the goal of preventing thrombosis without bleeding.
So what's your view on the novelty of direct thrombin or factor 10, 11 activity?
Well, I think the 2A inhibitors, the direct thrombin inhibitors, have all shown a propensity for bleeding. And compared to warfarin, and there have been a number of trials trying to compare with warfarin for bleeding, they've all failed to show a decreased bleeding diathesis. Factor 10A has less bleeding than the 2A, but still has a significant bleeding risk. This is where the further we go up, maybe factor 11 will deliver on its promise. I think we still have to wait and see. But 2A and 10A definitely have a significant bleeding risk that comes with every patient.
So it's the 11 that maybe?
Maybe.
I share the view, and I would say that for factor 2, direct thrombin inhibitor or factor 10A inhibitors, we've clearly seen from all the clinical studies that have been done with these type of drugs that there is a very good coupling of exposure of the drug and efficacy as well as bleeding, which means that you can't really expect that you can develop more effective factor 2 inhibitors or factor 10A inhibitors without the bleeding risk coming as a penalty. Where you can improve on these type of drugs, that is reduce variability. But I think that the last compounds in those series, they have fairly good, i.e., what I mean, low variability within patient or between patients. So I think that you need to go for different ways of affecting the thrombosis. Factor 11 looks promising, but we still don't have the final proof. Then as we discussed, these new preclinical compounds with more than one target built in, they look very promising. And here I think there could be a parallel to what we see in general prevention of cardiovascular disease, where the polypill has really shown now dramatic effects by combining low doses of different approaches, and you get very good efficacy with good safety tolerability. Similar, we see the same in the cancer area, where we are now discussing combination of several things in order to improve efficacy and improve safety tolerability. So there could be a parallel here that we should aim for also in the antithrombotic space.
Do you think that it's possible to combine a prostacyclin IP agonist and an HDAC inhibitor?
I do. There's a common belief now in the cardiovascular field that monotherapy will never be an effective and safe approach, and I would shadow what's been said, that it'll be polytherapy at the proper dosing that gives us that sweet spot of prevention of thrombosis without bleeding, and whether that is multiple antiplatelet targets, the right antiplatelet anticoagulant target. But I definitely think that targeting prostacyclin by activating it and inhibiting HDAC, at least from the preclinical data, seems that it could be an effective approach.
Yeah, and also the HDAC by itself, since you have the antiplatelet effect as well as the fibrolytic effect adding on.
There are some novel approaches to thrombosis treatment, and we have some major problems. What do you think, if you would like to have a kind of bird's eye view on the whole field, what are the major traits these days to accomplish the holy grail of antithrombotic therapy without bleeding?
Even with all the therapies we've developed, thrombosis still remains the #1 cause of morbidity and mortality. So the holy grail is going to be about bleeding. We can't hammer the platelet down. We need to be able to soften the platelet's activity in such a way that we don't go into secondary hemostasis or thrombosis. And so I think that's going to be the holy grail going forward.
And I agree. The most important thing is the very high prevalence of thrombosis-related disease in society. That's what makes me very enthusiastic about this. That is that in all activities I've been involved in developing new antiplatelets and anticoagulant drugs in the past, there has been very good translatability, and that means what you see in an animal experimentation can be then proven also in the clinical situation. So based on that, I think that the preclinical data we've seen so far is extremely promising, and it is of course now important to rapidly progress and getting these new exciting compounds tested in a clinical situation.
We are at ESC, and do you think, have you seen anything new or something presented that will have impact on the future thrombosis treatment?
Well, we did present the first data on CS014 at ESC, and it was widely accepted, and there was a lot of enthusiasm for the prospect of a brand new target for treating thrombosis without bleeding. We've seen other new areas, like Factor XI is rolling out their phase 1 trial, and there's some interesting data on that. But the CS014, I would say, is probably the most prominent new target that is being rolled out at ESC this year.
So what do you say, Gunnar? Have you seen something?
I haven't seen so far, and the reason being that tomorrow afternoon there will be a presentation on some new phase 2 data for a factor XI inhibitor. We should of course watch the space.
So I think that was a very, very good discussion we had, and I really thank you for taking time to come here today. Do you have any final word you want to say before we close the session?
I think we're in the golden age of thrombotic discovery, antithrombotic discovery. We're now identified new targets with plausible paths forward, and we haven't had that in a long time. And so I'm very optimistic that in the very near future we'll be able to translate some of these preclinical programs into the clinic and save lives.
These compounds in the preclinical testing, we haven't just done a target-based screening and found compounds. We've really done a type of phenotypic screening where we've seen effects on thrombosis and on platelets. And that is really why I say that translatability into the clinical situation is in this area higher than in many other areas of drug development.
Thank you.
Thank you.
For more episodes of our Insight series, please follow Cereno Scientific on LinkedIn or our YouTube channel.